Oh my God, that's close. I feel like my mouth is dry. All right, so who's in the legs? Me, I'm more of a coronary guy, but today's a peripheral day. Hi, my name is Will, and this is drug-coated balloon technology. Every time I see technology, I feel like I gotta do a little robot dance. Oh, who put that there? Anyone? Thank you. Thank you, thank you. You guys don't have to have zero conflicts of interest. So we should all know what PAD is by now, thanks to Ms. Malloy. As you can see, it is highly prevalent, but often underdiagnosed and undertreated, affecting up to 12 million Americans and more than 200 million people worldwide. These are some of the risk factors of PAD, some of which are modifiable. However, there are a few that we cannot change. Advanced age would be one of them, with the risk of PAD increasing dramatically with people over the age of 50. Everyone looks younger than 50, so we're good. Just by looking at this picture, who do you think is more affected by PAD? She looks very happy. All right, well, race and ethnicity is another non-modifiable risk factor. PAD is more prevalent with Hispanics, Blacks, Asians, Pacific Islanders, Filipinos. Wait, am I claudicating right now? PAD is not only lifestyle limiting, but when combined with poor patient education, poor self-care, and multiple comorbidities, it can lead to ulcerations, infections, and amputations. It can potentially be life-threatening. There are many ways to treat PAD, and as Dr. Cameron mentioned, prevention is obviously key as well as optimal medical therapy. However, when the responsive medications are inadequate, we have many tools in the toolbox. Here's a tool box. Shout out to Ray. So one would be the all-time classic POBA, or plain old balloon angioplasty. However, ballooning alone has many drawbacks, such as higher incidence of restenosis. We also have our BMS, DES, atherectomy, and lithotripsy devices, which Chris would be talking more about. Depending on the type of PAD, its severity, lesion length, patient's comorbidities, and persistent risk factors, choosing the right strategy and careful selection of tools is without a doubt the key to treating PAD. So stents have been introduced to help lower restenosis rates. However, some disease involves long segments where the outcome of stents are suboptimal. Also, the disease often crosses joint line that makes it less ideal for stents. Other complications in long-term indwelling stents are ISR, thrombosis, and stent fractures, to name a few, especially in the SFA and the popliteal region. All right. So we should all know and be anatomy masters by now, thanks to Ms. Darmanto. Can anyone tell me what we're looking at over here? That's correct. She read my slides. So right there's a stent fracture. DCBs were developed to combat this. Implant-free or leave-nothing-behind approach is a unique advantage and a breakthrough therapy in the treatment of PAD, especially in the femoral popliteal region. A little fun fact, the first one to use a DCB in the US is, drum roll please, our very own Dr. Krishnan. That was on October 11, 2014 at the Mount Sinai Hospital. So we're very proud. DCBs are intended to restore vessel patency while also also helping to prevent restenosis. The anti-restenotic drug used in DCBs is an anti-proliferative drug called paclitaxel, which is proven to be effective. This drug may sound familiar to you as paclitaxel is used in cancer treatment therapies. To deliver this drug, we need an excipient, a drug mule, if you will. Excipients are an inactive substance that serves as the vehicle or medium. It helps maximize drug adherence to the balloon during transit and drug release to the tissue upon inflation. It limits drug washout or flaking off. The paclitaxel and the excipient are kept in the folds of the balloon. Excuse me. These are some of the DCBs available in the market. Impact, Lutonix, Stellarex, also Ranger, to name a few. As you can see, all of them carry paclitaxel and have different doses and excipients. Not all DCBs are made the same. It may be the same drug with similar mode of action, but different technologies. With different coating methods and different types of drug formulation, some having crystalline and others having amorphous or a hybrid form of paclitaxel. DCBs were developed to combat the restenotic cascade. So to understand how that works, here's a little refresher. So we have the balloon or stent causing controlled dissections, which triggers an inflammatory response at the injured site, ultimately causing new cell growth, which leads to the Achilles heel of peripheral interventions, which is restenosis. So how do DCBs prevent this? Well, within 60 seconds of inflation, the paclitaxel is diffused through the vessel wall into the media and adventitia. This inhibits DNA replication, leading to apoptosis or cellular death, therefore preventing neointimal hyperplasia, preventing restenosis. So what are the factors influencing DCB performance? There's durability, deliverability, and uptake. DCB is not for every lesion. At least it's not FDA approved yet for other lesions, but lesion preparation must be optimal for the drug to be delivered, so we must be selective when using DCBs alone or having to use a combination of the tools we have in our toolbox. A lesion that may be problematic is a calcified lesion. It's a mechanical barrier causing significant recoil, as you see in the picture. Severity of the lesion calcification is associated with late lumen loss and decreases patency. This barrier prevents the uptake of paclitaxel, therefore rendering it ineffective. And here's a slide showing just that. The more calcified the lesion is, the higher the late lumen loss is and the lower the patency rates are at 12 months. Another challenge is the lesion length. This slide indicates that the longer the lesion is, the less patent the vessel would be at a later time. And as I've mentioned before, the excipients are an integral part of the DCB. Lack of an excipient dramatically increases the restenosis rate, as you can see in the study. Right there. All right, so let's talk about the SFA. SFA lesions are one of the main causes of intermittent claudication and critical limb ischemia. So it's important that we have the right tools to combat this. So why DCB? As you know, SFA and popliteal arteries are poor conduits for implants due to the location of the arteries, and as the picture shows, the older the person is, the more tortuous the artery becomes. This puts the patient at risk for stent fractures as well as increased rate of ISR, as you can see that graph. With DCBs, we can use an implant-free approach, which will avoid ISR occurrence and treatment burden. Drug-coated balloon preserves future options for revasc. Although it began as a novel idea, we've been using DCBs for quite some time now. Data shows the lesions treated with DCB have a higher rate of patency over POBA and fewer major adverse events. Just some case photos. As you can see, here's a lesion in SFA. We use atherectomy to prep the vessel, and then your DCB there, and the beautiful result in the last picture. All right. So I know there have been controversies regarding the increased risk of death and amputation with the use of DCBs, but it has been shown that those studies are of poor quality. A specific cause for the increased late mortality risk has not been determined in that 2018 meta-analysis. Dr. Farhan actually spoke about this last year at the CCC, for those of you who remember. And Dr. Systemski, I'm sorry if I'm butchering your name, but we'll be speaking more about this topic in a few minutes. So in conclusion, DCBs are safe. DCB technology is continuously evolving, and hopefully one day it will be FDA approved for the below the knee and the coronaries. Thank you, Dr. Krishnan, Ray Lascano, Beth, for this opportunity. And honestly, I hope I don't have to do this again. Thank you. If you don't have claudication, standing ovation. Thank you.